Hello, this recorded lecture will be going over Chapter 37, Care of the Surgical Patient in the Fundamentals textbook. There are many different reasons that a patient will need or have to go in for a surgery. A procedure can be elective, that means that it is voluntary. An example would be like a hernia repair that would be scheduled a week away. It could be an emergency surgery. This would be necessary in trauma cases in which serious consequences can occur if the surgery is not done immediately. You can do palliative surgery. This would be done to relieve pain and provide comfort. This is done to make a patient more comfortable. An example of this type of surgery would be removing a metastatic tumor from the abdomen that is causing considerable pain. Surgeries can be diagnostic. An example would be a biopsy of a mass. We do these types of surgeries to provide data for a diagnosis of a patient problem. Surgery can be reconstructive. An example would be a mammoplasty after a mastectomy. This is done to restore appearance or function. And surgeries can be curative. This is going to alleviate or cure a problem. For example, when you remove a gallbladder full of stones causing blockage or pain. The infant and the older adult are at a higher risk of surgical complications because of either immature body systems or a decline in function of their various body systems. Both of these age groups are at risk for dehydration or overhydration. Other types of patients who are at a higher risk during and after surgery are those with bleeding disorders, cancer, heart disease, chronic respiratory disease, diabetes, liver disease, immune disorders, chronic pain, upper respiratory tract infection, fever, or drug abuse issues. These patients are subject to a variety of complications and should be carefully assessed during the postoperative period. All patients are at risk for a surgical site infection. On page 750 in table 37.1, we can see some surgical risk factors. Diabetes and other chronic diseases, advanced age coupled with inactivity, a very young age, which would be our infant population, malnutrition, dehydration, obesity, cardiovascular problems, peripheral vascular disease, substance use disorder or alcohol abuse disorder, smoking, regular use of certain drugs. This doesn't only apply to recreational drugs. Notice how in the key points it mentions aspirin and anticoagulants, as well as corticosteroids, and excessive fear. Perioperative nursing refers to care of the patient from the time of the decision to have surgery through recovery from the procedure. Surgery can be performed as a same-day or outpatient procedure, or as an inpatient procedure in a hospital or surgery center. Preparation for surgery will begin prior to admission. Patient education for postoperative care needs to be done efficiently because the length of stay will be short to reduce any hospitalization costs. On page 751 in box 37.2, we can see some terminology for surgical procedures. Important to become familiar with these types of terminologies, because if you understand what the end of the word means, and then you understand what body part is in the beginning of that word, you can pretty much figure out what has been basically done. Lysis is the removal or destruction of, for example, lysis of adhesions. Anastomosis is joining two parts together, such as a duct or a blood vessel. Ectomy is cutting out or off, such as a colectomy, which would be cutting off a part of the colon. Ostomy is furnishing with a mouth or an outlet. An example of this would be a colostomy, which creates an outlet for the body from the colon. Otomy is cutting into, such as thoracotomy, cutting into the chest. Craniotomy, cutting into the brain. Plasty, this is a revision, a molding, or a repair of tissue. Examples would be mammoplasty. And pexy, this is going to be fixation or anchoring in place. For example, orchopexy, fixation of an undistended testicle in the scrotum. Laser surgery is common and often combined with microscopic, endoscopic, and robotic enhanced procedures. A laser is a tube that contains a medium, such as carbon dioxide or another active gas, that is then energized by electricity. The light beam can be converted to heat as the tissue absorbs it. Fiber optics will allow the use of endoscopes with high-resolution video cameras pass through a very small incision for an ever-increasing variety of surgical procedures. 2 or 3 puncture holes are often made so that the camera can fit through the incision. Robotics is seen as a key to the less invasive, less traumatic surgeries of our future. This equipment will require a specially trained surgeon or a surgical team in a special area or room. Remote-controlled instruments are inserted through small incisions, and some types of robotics are actually voice-activated by the surgeon. Providing precision, robotic instruments can provide precision that is beyond human dexterity. Because only small incisions are needed, the patient has less pain postoperatively, requires less time to heal, there is less scarring, and fewer infections are seeming to develop with this evolving surgical technique. Anesthesia is the loss of sensory perception, and this has been used for surgical procedures since the 1840s. There is a risk anytime a patient is anesthetized. The goals of anesthesia are to prevent pain, to achieve adequate muscle relaxation, and to calm fear, ease anxiety, and induce forgetfulness of an unpleasant experience. The choice of anesthetic will rest with the anesthesiologist or the nurse anesthetist, considering the type of surgery to be performed, the patient's age, and their physical condition. General anesthesia is induced by the administration of an inhalant gas or an IV medication. During general anesthesia, the patient is in a deep sleep state with muscle relaxation and is not aware of anything going on in the operating room. General anesthesia has 4 stages. When the patient awakens from anesthesia, progression through the stages will occur in reverse. We can see the 4 stages of anesthesia on page 752 in box 37.3. Note that stage 2 is the excitement phase. The muscles will become tense, but swallowing and vomiting reflexes are still present. Breathing can become irregular, or the breath may be held. The environment should be kept quiet during this period. Also see on page 752 the lifespan considerations for the older adult. Accurate height and weight data of the older adult are very important to obtain calculation of anesthetic agents and medication dosages. Kidney function declines in the older adult, and this means that drugs are not eliminated from the body as quickly. Reduced dosages are often needed for our older adult patient. Regional anesthesia is accomplished by administering a nerve block. The block anesthetizes the local area or the area distal to the block. Spinal or epidural blocks would be an example of this type of anesthesia. A local anesthetic agent at the surgical site plus IV sedation is used to provide systemic analgesia, also known as conscious sedation. Conscious sedation means that the patient is actually aware of their own surroundings, but they are sedated and have depression of their autonomic nervous system. This allows us to accomplish procedures with the patient experiencing less pain and also able to be more cooperative because they are not in so much pain. The patient is very closely monitored for any blood pressure changes, oxygen saturation levels, and heart activity. Typically, a respiratory therapist would be at the bedside for this, monitoring capnography levels. And then, of course, the nurse is going to be available and monitoring the vital signs as well as a RASS and Aldrete score every 5 minutes. Local anesthesia is used for minor procedures, such as superficial tissue biopsies, surface cyst excision, insertion of a pacemaker, and insertion of a vascular access device. Care of the surgical patient is divided into 4 phases: preoperative, intraoperative, post-anesthesia immediate care, and postoperative care. A surgical consent form must be signed before surgery and before preoperative medications are given. This is a legal form and it must be completed in ink with the correct spelling of procedures to be done. The surgeon is responsible for obtaining the informed consent. Any questions the patient has need to be answered at this time. If the patient does not understand the procedure or has further questions for the surgeon, you need to refer the matter back to the surgeon, which means call that surgeon in, tell him the patient has questions, get him to the bedside or on the phone so he can answer those questions for your patient, and then you can legally have them sign the consent form. If a patient is a minor, is confused, or is mentally incompetent, another responsible party, such as a parent, spouse, or guardian, needs to be present for the explanation and might need to sign the consent form. The signature of the patient or the responsible party is witnessed by another party, often a staff member. This consent form needs to show the procedure to be performed and the risks involved. It needs to include the time and date and must be signed with ink. A witness X is acceptable if the patient cannot sign with a signature, if allowed by your institutional policy. If emergency surgery is needed and the patient is not conscious or able to give consent, immediate family is contacted. Telephone permission may be given as long as there are 2 witnesses on extension lines. If a family member cannot be found, the opinion of a second surgeon regarding the need for surgery is sought, and then the surgery can take place. All responsible adults are asked to complete advance directives when they're admitted to the hospital if they did not already have a document on file. If you're taking care of a patient and you notice that part of the consent form is misspelled, you need to request a corrected consent be signed. On page 753, see the cues and considerations for safety regarding our Universal Safety Protocol. As part of the National Patient Safety Goals, the Joint Commission has developed a universal protocol for facilities to prevent wrong site, wrong procedure, and wrong person surgery. This protocol consists of 3 parts. First, a pre-procedure verification process, then marking the procedure site. The patient needs to be involved in this process if possible, in marking the procedure site. This should be done before any preoperative medications have been given so that the patient is alert and able to participate fully. Then we perform a timeout before the procedure is completed or started. The referring provider, the surgeon, or a surgical resident will take a medical history, perform a physical exam, and order the necessary tests. The patient should be in the best possible physical condition for surgery, unless it's an emergency procedure. During the preoperative period, the patient is prepared physically and psychologically for surgery. It's important as a nurse to ask open-ended questions and listen attentively. An important part of your assessment is determining the supplements and herbs that a patient consumes. Besides checking for any drug allergies, you also need to determine if the patient has a latex allergy. Psychosocial assessment will include fears, attitudes, and any concerns about changes in body image or lifestyle that the surgery may cause. The OR should be notified if the patient is hard of hearing, has impaired vision when glasses are not in place, or has a prosthesis. Cultural beliefs and values regarding surgery need to be considered. A patient's family member should not be used as an interpreter due to confidentiality and possible errors with translation. If the patient's culture has certain taboos regarding an aspect of surgery, the surgical team needs to know about them and plan a way to achieve a good outcome without violating those taboos. It's especially important to know whether or not your patient will accept a blood transfusion. General goals for all preoperative patients will include being prepared for surgery physically and emotionally, being able to demonstrate deep breathing, coughing, and leg exercises, being able to verbalize understanding of the procedure they are going to undergo and the expectations of them in the postoperative period, and to be able to maintain fluid and electrolyte balance throughout the perioperative period. At the beginning of the shift, check to see that any ordered preoperative medications are on hand. Check the surgery schedule and estimate the time that the patient will need to be prepared for their surgery. Preoperatively, divide your time between preparing the patient for surgery and patient education about what will happen and how to assist them in the recovery period. Always sending written instructions home with the patient will reinforce the information that has been taught. Teaching a patient breathing, coughing, turning, and leg exercises is a high priority during the preoperative period. The stasis of blood, which is the stoppage of flow, will place the patient at risk for thrombophlebitis, a blood clot. Be sure to explain the importance of doing exercises and then show the patient how to do each one. Always ask for a return demonstration, as this is the best way to verify that learning has occurred. For deep breathing and coughing, it is preferable for the patient to sit up with the back away from the mattress or chair. Deep breathing and coughing should be performed every 2 hours for 72 hours after general anesthesia. Instruct the patient about what to expect before, during, and after their surgery. Food and fluids are restricted before surgery, and the patient is placed on an NPO, nothing by mouth status. Always check the medical order before giving anything by mouth in the immediate preoperative period. The purpose of the restriction is to prevent vomiting and aspiration, which can occur but is rarely seen with modern anesthesia. If the patient is having colon surgery, enemas may be ordered to be given until clear. Be sure to remember that we want to call the doctor after an administration of 3 successive enemas, as that could place the patient at a serious risk of fluid and electrolyte imbalance. If a nasogastric tube will be inserted during surgery for postoperative care, be sure to explain its purpose, its care, and what it will feel like to the patient. Explain the function, the care, and the probable duration of any use of expected tubes, such as drains, an IV line, any oxygen delivery, monitoring devices, a chest tube, or a urinary catheter. It is desirable for the patient to be as well rested as possible before their surgery, so that the body is not compromised in meeting the stresses of anesthesia and the procedure. Many surgeons will order a patient-controlled analgesia pump, or PCA pump, for their patients postoperatively. The patient should receive instruction about this pump before the surgery and how to operate it. The patient might be asked to shower with a special antibacterial cleanser on the night or morning before surgery, or maybe both. This is to remove as many microorganisms from the skin as possible. Removing hair from the operative site may be done just before surgery, but it's generally not recommended. Patients should be instructed to avoid shaving near their surgical site to prevent any infection. In the immediate preoperative care period, dress the patient in a clean hospital gown with underwear removed to be prepared for the OR. Have the patient remove any jewelry, money, and credit cards, and have them give these valuables to a significant other to keep secure. Or instead, if that's not an option, you could secure them in a valuables envelope and place it in a locked environment, such as with security. If a wedding band is to be worn to surgery, tape it to the finger without restricting any circulation. Check the patient's ID bracelet against the medical record for accuracy to avoid any error or mix-up of patients in the OR. Attend to all items on the preoperative checklist that can be handled ahead of time and early in the morning. If the facility wants the surgical area to be marked before the patient leaves the room, be sure to confer with the patient and appropriately mark, or even have the patient mark the appropriate site, according to your agency policy. Always seek feedback from the patient and document that the site has been marked properly. Compare the patient's ID bracelet, name, and numbers with the transport request sheet. Most preoperative medications will be given intravenously in the surgical holding area rather than on the nursing unit. Preoperative medications are given to reduce anxiety and promote a restful state, to decrease secretion of mucus and other body fluids, to counteract nausea and reduce any emesis, and to enhance the effects of the anesthetic. While patients are in surgery, prepare the patient unit for their return. Make their bed with fresh linens, including a draw sheet placed at shoulder height. Place an underpad at the hip area. Fan fold the top covers to the far side of the bed or to the bottom of the bed. Have the bed raised in a position at the height of the gurney that will return the patient, and arrange the furniture so that the gurney can be pulled up easily alongside of the bed. Gather an emesis basin, tissues, or workstation on wheels, frequent vital sign sheet, or a postoperative care record, an intake and output sheet, a small towel and washcloth, a pencil, and place these items on the bedside table or console. Place an IV pole at the head of the bed. Connect oxygen and suction equipment if their need is anticipated. A thermometer, sphygmomanometer, and stethoscope, as well as pulse oximeter, should be nearby for when the patient returns to the unit. If a PCA pump, sequential pneumatic compression devices, which are SCDs, or a passive range of motion machine will be needed, be sure to see that they have been obtained and are ready for use. If the patient is properly prepared for surgery, is kept NPO, is reasonably calm and knowledgeable about the procedure as well as what is expected of them, then the general goals have been met. The patient is transported to a holding room during the intraoperative care. Then the circulating nurse will verify the patient's identification and verify that all preoperative orders have been completed. The surgical consent form will be checked to ensure that the patient has been prepared for the correct surgery on the correct body part. Any ordered preoperative medications will be administered, and when the OR is ready, the patient will be transferred to the operating table. All personnel who enter the OR will wear clean scrub outfits, hair covers, shoe covers, and masks. The surgical team, including the surgeon, assistant surgeon, and scrub person, will perform a surgical scrub prior to entering the room. Strict surgical asepsis is mandatory throughout the surgical area. Maintaining a normal body temperature in surgery is important in the prevention of any surgical infections. Prevention of hypothermia can be done by active warming during the surgery with a forced air warming blanket and pre-warmed IV fluids. A surgical technician or specially trained nurse can be the scrub person. A licensed nurse will usually fulfill the duties of the circulating nurse. The period immediately after surgery with general anesthesia or after a major procedure performed with spinal anesthesia is a critical time and requires constant observation by specially trained nurses. The PACU will provide care for all of these basic needs. The patient will be positioned to prevent any aspiration and promote their lung expansion. The patient should be kept warm by covering them with warm blankets and is reassured that the surgery is over. Vital signs need to be taken every 5 to 15 minutes until stable. The anesthesia recovery period typically takes 2 to 6 hours. The patient will remain in the PACU until their vital signs are stable and they are awake and able to respond to stimuli. Many facilities will use the Aldrete scoring system to determine readiness for transfer. This scoring system will rate a patient's activity, respiration, circulation, consciousness, and skin color on a scale of 1 to 3. A total score of 9 or 10 would typically indicate that the patient is ready for a transfer. In the PACU, the environment needs to be kept as quiet as possible. For many procedures, the patient may be transferred from the OR directly back to the same-day surgery unit. When vital signs are stable, the patient should be allowed to sit up and begin to ambulate. Recovery time in the same-day surgery unit will usually take about 1 to 4 hours. Written instructions need to be sent home with the patient. On page 765, see box 37.6. Functions of the circulating nurse and the scrub person. A major function of the circulating nurse is to observe for any breaks in sterile technique and then announce them to the team. Very important. On receiving the patient from the PACU nurse, check their identity, settle them in bed, and perform an initial postoperative assessment. Vital signs and careful assessment need to be performed every 15 minutes for the first hour, every 30 minutes for the next 2 hours, and every hour for the next 4 hours. Then every 4 hours until the patient is completely recovered from anesthesia and vital signs have returned to normal. General nursing goals for patients in the postoperative period are to maintain a patent airway and an adequate respiratory exchange, to maintain adequate tissue perfusion, to promote comfort and rest, as well as wound healing, to promote psychological adjustment and prevent complications. When planning your shift work, be sure to allow time for frequent postoperative assessments. The nurse must protect the surgical patient from any injury, promote respiratory function, promote circulation, maintain fluid balance, promote GI function, promote comfort, promote rest and activity, prevent infection, and monitor for complications. Maintaining an open airway is a priority measure. The patient must be positioned on their side or with the head turned to the side to prevent any aspiration. If not contraindicated until fully recovered, alert and with the swallowing reflex intact. The side rails need to be kept raised for safety until the patients are fully recovered from the anesthesia. A feeling of pins and needles in the legs can be common. The patient is prone to hypotension until all effects of the spinal anesthesia have been resolved. If a headache develops, keep the patient flat to reduce their pain. Be sure to check the surgical site when the patient returns to the unit. The dressing should be dry. If it's stained, outline the area with the pen and note the time so that further bleeding can be assessed later. If the bleeding has saturated the dressing, reinforce with more dressing supplies. The dressing should not be changed without an order to do so. Check the surgical site each hour for the first 4 hours, then every 2 hours if bleeding has not occurred. Be sure to check the bed linens underneath the patient as well, because sometimes blood can run under the dressing and will pool under the patient. Be sure to assess drains for patency when checking the wound, and empty and recompress drainage devices as needed. Common types of drains left in to help remove fluid from the surgical site include Penrose, Hemovac, and Jackson Pratt bulb drains, chest tubes, and a T-tube to the common bile duct. The postoperative patient is at risk for respiratory problems due to the effect of anesthesia on the lungs, from being in one position in the OR table for the duration of surgery, and from the limited mobility in their immediate post-op period. Atelectasis, which is the collapse of alveoli in the lungs, will exist to some degree after anesthesia. A mild hypoxia is typically present for about 48 hours postoperatively. Be sure to auscultate the lungs carefully, for note any absence of sound or the sounds of crackles, which could indicate retained secretions. Be sure to assess the rate and depth of breathing and encourage the patient to deep breathe and cough every 2 hours. Coughing can be contraindicated for patients who have had hernia repair or eye, ear, or brain surgery. Be sure to check your surgeon's orders. Coughing will mobilize secretions for expectoration. If the patient cannot cough effectively, instruct them to take a deep breath and forcibly exhale with the mouth open. Have them repeat this huff maneuver again, and then ask them to take a deep breath and cough strongly as they exhale to move the secretions out of the airways. Signs of complications are complaints of shortness of breath, pain on inspiration, and extreme fatigue. The use of an intensive spirometer is especially helpful to prevent any atelectasis and hypoventilation. The older adult might need some extra coaching to master this technique. A pulse oximeter should be used to determine blood oxygenation. Monitor these readings periodically and report any arterial oxygen saturation readings below 92% to the provider. When considerable blood is lost during surgery, a transfusion may be ordered. Autologous transfusion may be done if the patient had donated blood several weeks before their surgery, or if the patient's blood was collected as it was lost during the procedure. That blood would then be filtered and returned to the patient. When the procedure involved an extremity or the pelvic area, be sure to check the distal or peripheral pulse during each full assessment. The skin should be warm to the touch, and there should be good capillary refill in all fingers and toes. Blood pressure and pulse should be compared with preoperative values to determine any significant changes. If the patient is at risk of venous thrombosis, a blood clot, the surgeon will typically order sequential pneumatic compression devices to be applied to the legs and/or an anticoagulant. These devices will alternately compress, release, and squeeze the vessels to propel the blood among them. The urine output needs to be monitored after surgery. If the patient has an indwelling catheter, the urine in the bag needs to be observed every hour in the early post-op period. If the urine flow is less than 5 mL per kg per hour, report it to the charge nurse. If the flow is less than 60 mL over a 2-hour period, notify the surgeon immediately. Check the catheter to ensure that it's not kinked and that the connection tubing is not lying beneath the patient. If no catheter is present, the patient needs to void within 8 hours of their surgery. The patient will typically have an IV infusion running when they return from their surgery. Depending on the type of surgery, these IV fluids can be continued for a few days or might be discontinued after that fluid finishes infusing. No potassium additive should be given until the urine flow is at least 5 mL per kg per hour. Assess the IV site for patency and signs of infiltration when vitals are taken. As soon as the patient is conscious and the swallowing reflex has returned, offer the patient a few ice chips or sips of water, unless there's an order to maintain NPO status. We do this to assess the ability to swallow, and it is very important. Be sure to record any intake on the intake and output record. The body will initially retain some fluid due to the stress that it was undergone during the surgery. Anesthesia can make the patient nauseated, and vomiting can occur. The surgeon will typically write an order for a medication in the event of excessive nausea or vomiting. It's best to medicate the patient before the actual vomiting occurs. When an NG tube is in place, check that the suction is set according to the orders and is working properly. Assess the amount of drainage produced every 1 to 2 hours. If the tubing is kept above the level of the stomach, the drainage will occur more easily. Be sure to report any presence of blood to the surgeon. Eating is not allowed until bowel sounds have returned after surgery and general anesthesia due to the risk of any development of paralytic ileus. This is the failure of the forward movement of bowel contents. Be sure to listen for bowel sounds and document them at least once per shift. After the patient has started eating again, they should have a bowel movement within 2 to 3 days. If the patient is complaining of pain upon the return to the unit, check the notes from the PACU and see if any pain medication was given. If respirations are within normal limits and there are no contraindications to doing so, medicate the patient promptly with the ordered pain medication. Note when the analgesia is due and have it ready to administer at the appointed time. The patient can feel cold and should be kept warm with extra blankets or warm bath blankets applied under the top covers. Be sure to check with the surgeon or the charge nurse before loosening any dressings. Abdominal distension and considerable flatulence can occur after general anesthesia due to the GI tract action stopping. This can cause discomfort for the patient. Ambulating can be helpful in moving and evacuating that extra gas. Taking only small amounts of liquid or food at a time, drinking liquids that are neither very hot nor very cold, and refraining from drinking with a straw will help keep gas to a minimum. If permitted, the patient can try resting in a slight Trendelenburg position with the legs and rectum higher than the stomach. This can assist in the evacuation of flatulence. Chewing gum, if permitted, will also help aid the return of proper GI function. Occasionally, continuous hiccups after surgery will occur. This makes the patient quite uncomfortable. Having the patient breathe into a paper bag can often relieve these hiccups, but persistent hiccups may require a more vigorous treatment to be prescribed by the provider. The patient needs to sleep after surgery. Every 2 hours, the patient needs to be doing leg exercises and change their position. Orders for ambulation may begin 8 hours postoperatively. Raise the head of the bed first, then let the body adjust to that position change. Next, sit the patient on the side of the bed, allowing the legs to dangle over the side of the bed with the feet on the floor. Stay in this position for a few minutes and then slowly help the patient to stand. Pain medication can be timed so that it's effective but the patient is not too groggy to participate in ambulation or activity. Do not rub the legs to promote circulation because an action such as that can disrupt a clot that has maybe formed and can cause an embolus, which will be a clot that will travel to another part of the body. Continue to ambulate on a set schedule until the patient is out of bed independently. If the patient is on bed rest, range of motion exercises need to be performed at least 4 times a day. Aseptic technique must be used when caring for the postoperative patient. Good hand washing is the primary means of preventing any infection. Encouraging fluids to flush the bladder will help prevent a bladder infection for the patient who is catheterized or has an indwelling catheter. Inspect the surgical wound site each shift and assess for signs of infection, including local pain, increased tenderness, warmth, redness, or purulent drainage. A major nursing responsibility is continuous monitoring for signs of the various complications that may occur during surgery. Dehiscence is the separation of layers of the surgical wound, and evisceration is the extrusion of the viscera through the surgical incision. These can occur when the patient is coughing, particularly if the abdominal incision is not properly splinted. General goals after surgery include lungs being clear to auscultation, peripheral pulses present, pain controlled for 4 hours with analgesia. Incision should be clean, dry, and without redness. The patient should state that they are glad they will not have periods of pain and fatigue anymore, and there should be no signs of thrombophlebitis or infection.